Hi everyone, welcome to Dr. Deepa's Learning Launch. This is Dr. Deepa and I'm here to discuss the case that I shared on the WhatsApp group today. So that was a whole slide image of the meninges that had Cryptococcus infection. So we will discuss the details of cryptococcal meningitis today. So first let's look at the whole slide image that I had shared. So this was the whole slide image that I had shared. So we will evaluate the meningeal biopsy, which very clearly shows a fungal organism which is roundish, and you're seeing that it is nearly the size of an RBC, and you're seeing a thick wall around it and a halo around these areas. So if you see, there is a soap bubble appearance around these organisms wherever you're seeing. So one of the most important diagnoses to recognize in cryptococcal meningitis is its differential as well. So you just can't jump on the conclusion that it is cryptococcal meningitis by one histological section. I will tell you that several fungi and protozoal organisms can mimic cryptococcus histologically. So today we will discuss the important differential diagnosis and learn how to distinguish microscopically and review the three stains that to arrive at the diagnosis of cryptococcal meningitis. So first, cryptococcal meningitis is caused by Cryptococcus neoformans or GATI. So let's begin with the first description of the organism of interest. So Cryptococcus appears as round, oval, narrow-based budding yeast, roughly the size of 4 to 10 micrometers, which means it is around the size of half the RBC to a complete RBC size. You nearly see it at the size of an RBC. So the most characteristic feature of Cryptococcus is its mucopolysaccharide capsule, which is thick and prominent. So this creates a clear halo around the organisms in a H&E slide. So if you notice that these organisms have a narrow-based budding and not broad-based. In patients with advanced HIV infection, there is often a minimal inflammatory response around these organisms because of profound immunosuppression. Instead, you would just see the organisms have accumulated in large numbers that produces this classical soap bubble appearance that you're able to see on your screen right now. In an immunocompetent person, this appearance may not be there. In the sense, the person will be fighting off this infection, so there will be a granulomatous inflammation around it, and the number of organisms may be very low, sometimes very difficult to pick up on histopathology at all. So for confirmation, the capsule usually stains beautifully with mucicarmine and Alcian blue, while the fungal cell wall stains with PAS and GMS. Mucicarmine is your key stain of interest because only Cryptococcus is positive for that, and that is a key differential with other organisms. So let's further discuss some cases which can mimic this. One differential is just having the spores of Candida. If you just see the spores of Candida and you don't see any hyphae, then those spores also can look a bit like Cryptococcus, but that halo will not be there. The thick capsule will not be there. So if you find a pseudohyphae, then you really are sure that it is Candida. Candida should immediately come into mind because unlike Cryptococcus, Candida does not produce the thick wall. And so mucicarmine stain will definitely be negative when you subject this tissue to mucicarmine staining. Both PAS, GMS stains come positive in both the organisms. So it's of no use to differentiate. Another important differential is Histoplasma capsulatum. So histoplasma is another important mimic. These organisms are much smaller, roughly the size of half of an RBC, which is 3 to 5 micrometers. They exhibit about the same narrow-based budding that cryptococcal organisms show. And the characteristic differential is that histoplasma is more intracellular. You see them in macrophages mostly, and their intracellular location is an important clue. And the size of the organism is 1/2 the size of Cryptococcus. And another important differential is the capsule is not present, so mucicarmine is negative in histoplasma. So when you see numerous tiny organisms which are tightly packed inside macrophages, your doubt should go towards histoplasma rather than Cryptococcus. And mucicarmine is definitely a differential stain. Another differential that I can think of is blastomyces. Blastomyces is much easier to distinguish because it's much larger than Cryptococcus, and the budding is broad-based. In the sense, the area where the budding is happening between the two organisms, the base is very broad. So that is another very frequently found organism, and it produces suppurative granulomas and microabscesses. That is another important diagnostic clue and does not really elicit a granulomatous type of information. So Cryptococcus shows a narrow base budding while blastomyces shows a broad base budding. That is how you differentiate the two. Coccidioides immitis is another differential. So coccidioides looks completely different from the other fungi. So the other fungi you see budding yeast, but in coccidioides you don't find budding yeast. Instead, you see spirules which can have up to a lot of microspores inside it, and these spirules can reach the size of about 250 micrometers. So they are much larger. And inside these are numerous small endospores, and each of these endospores are about 2 to 5 micrometers. So you see multiples of these spirules in the histology sections, and these endospores release into the surrounding tissue. So that's a picture that you see in coccidioides. You really don't find budding forms anywhere. And another differential I can think of is paracoccidioides. Paracoccidioides is again another classical microscopic appearance because it has a central cell that give rise to multiple narrow buds right around it. So it looks like a mariner's wheel or the cogwheel kind of an appearance. So that again has blastomyces produces only broad-based budding. Like I already told you, paracoccidioides has a classical appearance of the cogwheel appearance. So whenever you see any of these organisms, it's very easy to differentiate that from Cryptococcus. Another thing is acanthamoeba or Balamuthia, which is not a fungus, may enter the differential diagnosis of a granulomatous meningoencephalitis, and you should be able to pick that up. Histologically, they have trophozoites and cysts. The nuclei often have a large prominent nucleolus and no budding yeast. So that is how you differentiate it from Cryptococcus. And these infections mostly produce necrotizing kind granulomatous inflammation. One more differential you have to remember when you're thinking of granulomatous meningoencephalitis is toxoplasma. Toxoplasma is an important mimic in an immunocompromised patient. Rather than the yeast, you will be able to identify clear crescent-shaped tachyzoids that you cannot miss. So there is no yeast, budding yeast kind of a picture in the toxoplasma. Yes, but you will be able to look at the more detail mainly in the higher magnification. The stains that are of importance is PAS and GMS. They will identify all the fungi. Cryptococcus, it is very important to do a mucicarmine stain because this highlights the polysaccharide capsule, which is not there in any other fungus. So your main differential stain is for identifying Cryptococcus is mucicarmine. And another thing is Fontana Mason also might demonstrate the melanin on the fungal wall. That also you can use it. So histological clues favoring Cryptococcus is a narrow base budding, roughly the size of an RBC, and then you will be able to identify the organism on mucicarmine. Another important thing is you can do an India ink stain also to identify Cryptococcus. Okay. So without much ado, let me just go ahead and show you a differential table. So if you see this differential table here, whatever we spoke about is clearly elicited in this table. So what you're able to see here, this is the picture of Cryptococcus. So what you're able to see here is roughly the size of an RBC. You see these rounded organisms. They are about 5 to 8 microns in size. And mucicarmine will clearly show you the organism. And another diagnostic stain is India ink. So this is your candida with pseudohyphae and spores. Sometimes the spores may mimic Cryptococcus. They are much smaller and they are not mucicarmine positive. This is histoplasma. In histoplasma, as I told you, they are macrophages that have engulfed this organism. And intracellular location is an important identifying feature of histoplasma. And the size of the organism is 1/2 the size of Cryptococcus. In the sense, it's 3 to 5 microns in length. And this is blastomyces, and you're able to see this area. This is the important area where you have to focus. So here you are able to see this broad-based budding yeast, right? So this is blastomyces. And then coccidioides, I told you, coccidioides, you won't be able to find any budding yeast in the background. You will only be able to see these large spirules, which can have many microspores. So they can range up to 250 microns in length. And here I told you paracoccidioides, they have a cogwheel kind of an appearance or mariner's wheel kind of an appearance where you have a single mother cell and multiple budding yeast right surrounding it like a corona, right? So that is paracoccidioides. Acanthamoeba, I told you, you'll have a clear nucleus and a nucleolus in the acanthamoeba, which is again a differential for granulomatous meningitis. It's not a fungus. And toxoplasma, I told you, they have crescent-shaped tachyzoids that you can identify. So this is the entire differential of cryptococcal meningitis. So very clearly, histologically, you will be able to pick up the key differential stain for differentiating from other fungus is mucicarmine and India ink positivity, both of which are because of the capsule. So before we end this talk, it is very important for us to discuss the latest advancements in cryptococcal meningitis diagnosis. Do we still rely on picking up these organisms on CSF or tissue? What if the patient is immunocompetent? There's just granulomatous inflammation and then you hardly have any organism. Are you still going to waste your time on these tests that we have spoken about till now? No. The diagnosis of cryptococcal meningitis now relies on three major approaches. One is microscopy, which we already in detail spoke about. The second is the culture. Third is the cryptococcal antigen detection. Today, cryptococcal antigen lateral flow assay or LFA is considered the frontline diagnostic test. First, we generally do for a CSF in India in kind of a thing which is inexpensive, widely available. I will show you a picture of one case of mine soon in the next slide. So it's very inexpensive, but the sensitivity is about 86% if there is a good fungal load. And it drops to about 42%, especially in immunocompetent patients where the fungal load is low. So are you going to risk that every alternate patient of yours can go undiagnosed? You can't risk it. So India Inc should never be used as the sole diagnostic test unless you've already picked up that and the load is very high. The second type of test that you can do for Cryptococcus is the fungal culture. It is a gold standard. It confirms the diagnosis and allows the quantification of the fungal burden, but it is only useful and it is also useful for monitoring response and differentiating relapse from immune reconstitution inflammatory syndrome. That is very important to differentiate. But there is a flip side to it. The culture requires laboratory infrastructure, trained personnel, and can take about 7 to 10 days. In the 10 days, the patient can become moribund. So you just can't wait for the fungal culture to come positive. And false negative tests are always common in an immunocompetent person. If in case the fungal load is low, then this can fail. It can give you a false negative result. The most important advancement in crypto is cryptococcal antigen detection using the lateral flow assay, which is a gold standard now. And as it is used as a rapid point of care test, it detects the capsular antigen in CSF, serum, and plasma within about 10 minutes. It is inexpensive again, it's not very expensive, stable at room temperature, and requires no sophisticated laboratory personnel who as much as the culture does. So blood cryptococcal antigen is highly sensitive, so it is good for any HIV patient with a positive serum. But any person with a neurological symptom should undergo CSF examination only, and not blood cryptococcal antigen is not good enough. Cryptococcal antigen titers usually correlate with the fungal burden. In the sense, if it is greater than 1:1024, then that is considered to be associated with high mortality. But the titers cannot be used for monitoring the treatment. That is the only flip side of lateral flow assay. Because if you use this for monitoring treatment, then you need to understand that this stays positive for a very long period, even after a successful therapy. So the clinician will not be able to understand if the treatment is working for the patient or no, because this antigen will be positive for a long time, even after successful treatment. So what do you use in case you are monitoring the treatment? You've already detected it with LFA. Then what is to be advised to monitor the treatment? That is called beta-D-glucan test or BDG. It is less sensitive than cryptococcal antigen in the sense you don't pick it up as nicely as cryptococcal antigen LFA during initial diagnosis. But the BDG correlates very well to the fungal burden. So if there is BDG positivity as well, if you want to monitor the treatment response, then BDG is your go-to test. So it will help diagnose an active relapse or an IRAS kind of a picture from the fungal infection, which is not working out with the treatment. So elevated BDG levels is again poor prognostic because it means your treatment is not working. Finally, another test that I wanted to put a word about is the PCR assay. Anything such as a biofire panel or film array for meningitis panel, which is very well available in most of the noted laboratories, is highly accurate. And it has been reported to have a sensitivity and specificity nearing 100%. So that can differentiate Cryptococcus neoformans from Cryptococcus gattai also. That is particularly useful for IRAS kind of a scenario. So the key takeaway is cryptococcal antigen LFA is preferred frontline diagnostic test. Culture is the gold standard for, and culture and beta-D-glucan both are useful for treatment monitoring, and PCR serves as an adjunct. So these are the main advancements in cryptococcal diagnosis. So without much ado, let me share you the CSF or picture also. Or this is a recent patient. So here you are able to see that these are the cryptococcal organisms. This is a GMSA actually. So in GMSA stain, we could pick up so many organisms on CSF, and then we subjected the sample to India Inc also. So that you can see these halo-like areas in India Inc that is owing to its capsule. So that is another important microscopic key. So I hope you like this video. So stay tuned to www.talktodeepaslearninglaunch.com for more such video. So I will be sharing interesting cases every day. So stay tuned, like, subscribe my channel, and share it with all your peers who wants to learn more in pathology and advance in diagnostics. Bye-bye.